We can look at a child from the doorway and recognize immediately that she is in respiratory distress. Work of breathing as an arm of the PAT standardizes our rapid respiratory assessment. To assess work of breathing, listen for abnormal airway sounds, and then observe the child for abnormal positioning, retractions, and nasal flaring. Abnormal airway sounds reflect problems in the upper or lower airway. Abnormalities in the upper airway may result in snoring or stridor. Snoring is a low-pitched sound most often caused by decrease of tone of structures in the upper airway, resulting in partial airway obstruction. Stridor is a high-pitched whistling sound. It is heard on inspiration or inspiration and expiration when there is partial obstruction of the trachea or vocal cords. Obstruction of the upper airway can occur with a variety of illnesses or injuries, including altered level of consciousness, loss of muscle tone, viral or bacterial infection, foreign body aspiration, or blunt trauma to the neck. Abnormalities in the lower airway can lead to grunting or wheezing. Grunting is heard when a child exhales against closed vocal cords. This is done reflexively to increase lung expansion and maximize gas exchange in the face of hypoxia. Grunting is heard most frequently in children with pneumonia, pulmonary contusion, or pulmonary edema. Wheezing is a high-pitched musical sound heard when air is forced through partially obstructed small airways in the lungs. Wheezing is most frequently heard during expiration. It may be heard during inspiration and expiration when obstruction is more severe. Asthma and bronchiolitis are common conditions associated with wheezing in childhood. Next, observe the child's position of comfort. A child who assumes the sniffing position has a severe upper airway obstruction and is attempting to maintain a patent airway. A child who refuses to lie down or leans forward in the tripod position is maximizing use of the accessory muscles of respiration. When retractions are present, the child is recruiting accessory muscle power to support ventilation. Retractions may be seen beneath, between, or above the ribs, above the clavicles, or beneath the sternum. They are more easily visualized in a child than an adult. Nasal flaring may be a tip-off to moderate to severe hypoxia. While any of these signs indicates abnormal work of breathing, the presence of multiple signs is associated with more severe respiratory compromise. For example, a child with audible wheezing, retractions, and nasal flaring is more worrisome than a child with wheezing alone. By combining appearance and work of breathing, we can further define the severity of illness or injury and determine the urgency of treatment. Consider a child who is alert and active, but who has retractions and nasal flaring. This child is in respiratory distress. Although she may require interventions in the field, she can be further evaluated before treatment is initiated. On the other hand, a child who has abnormal appearance and increased work of breathing is in respiratory failure. Urgent intervention is needed to improve oxygenation and ventilation. Finally, a child with a history of increased work of breathing, who now has abnormal appearance and decreased respiratory effort, is fatigued and is at risk for respiratory arrest. Assisted ventilation must be started immediately.